Ankle sprains. Perhaps the most deceptively simple of all orthopedic injuries, and yet one of the most frequent reasons that athletes, weekend runners, and even ordinary individuals are forced to step away from activity, sometimes for weeks, sometimes for months. At first glance, it may appear trivial: a quick twist of the foot, a stumble off the curb, the awkward landing after a jump. But behind this seemingly minor accident lies a cascade of biomechanical forces and structural vulnerabilities that make the ankle uniquely prone to injury. In fact, among all causes of missed participation in sports, ankle sprains stand at the top, a silent epidemic of instability and pain that touches every level of athletic competition. The diagnosis, more often than not, is clinical, and it begins with the story told by the patient's in-body. The ankle, freshly injured, swells dramatically, as if trying to cushion itself from further harm. The skin darkens with ecchymosis, the telltale sign of ruptured vessels just beneath the surface, painting the ankle in shades of blue, purple, and black. Pain emerges with every attempt at movement, simple flexion, extension, or rotation transformed into sharp reminders of the trauma sustained. Here, the experienced clinician does not immediately reach for advanced imaging. Instead, he listens to the language of the ankle itself. Radiographs are not a reflex, but a decision guided by structured reasoning, most famously the Ottawa ankle rules, criteria that help separate those injuries requiring further investigation from those where clinical judgment alone suffices. It is a dance between evidence and intuition, precision and restraint. Treatment, too, follows a philosophy that is at once practical and elegant. The ankle does not want to be locked away for long periods of time, imprisoned in casts or rigid boots that rob it of its natural motion. Instead, the modern approach embraces only a brief span of immobilization, a short reprieve that allows tissues to rest, inflammation to settle, and pain to subside. And then, almost immediately, movement returns, not reckless or forced, but guided, structured, and purposeful. Early functional physical therapy becomes the cornerstone of recovery, retraining muscles, restoring proprioception, and gently coaxing the ligaments back toward stability. It is a philosophy that recognizes the body's own need for motion and the dangers of excessive stillness. Yet, in rare and more sinister cases, the path of healing does not follow so easily. When the syndesmosis, the delicate but crucial articulation between tibia and fibula, tears apart, the ankle loses not only its strength, but its very architecture. Tibio-fibular diastasis, that widening of the mortise, is no minor sprain, but an injury that destabilizes the entire joint. In such moments, conservative care is no longer enough. Surgery steps in, not as the first option, but as the last defense against chronic disability. And even beyond acute trauma, there exist those unfortunate individuals who live in the shadow of recurrent sprains, each twist easier than the last, the ligaments stretched and weakened, until the ankle itself becomes unreliable, treacherous in its betrayal. For them, too, operative management may be the key, not to restore what was lost in a single instant, but to rebuild stability eroded over time. Thus, what begins as a simple twist of the foot evolves into a profound narrative of diagnosis, decision-making, and treatment. Ankle sprains may seem commonplace, but within their story lies the essence of orthopedic medicine, the balance between rest and motion, between restraint and intervention, between the body's resilience and its fragility. And so, as we begin this journey into the science and the art of ankle injuries, we must learn to look beyond the superficial bruise and swelling, and instead appreciate the deeper interplay of anatomy, biomechanics, and clinical wisdom that guide us toward healing. If ankle sprains is so familiar, almost mundane in the eyes of the public, it is only because they occur with such astonishing frequency. From the perspective of epidemiology, they are not simply one injury among many. They are the single most common reason why athletes are forced to step away from participation. Time and again, the same story repeats itself. The misstep during a high-stakes game, the awkward landing in training, the sudden inversion on an uneven surface. No matter the setting, the consequence is the same: an ankle betrayed by its own mobility, sidelining the competitor. In the long ledger of sports medicine, no injury occupies as much space as the humble ankle sprain. And yet, the distribution of this injury is not entirely uniform. Certain groups seem almost destined to encounter it, as if their very discipline places them on the knife's edge of instability. Among dancers, for instance, ankle sprains represent not just a frequent annoyance, but the defining injury of their art. The relentless demand for pointed toes, extended positions, and repeated landings from jumps stretches the limits of ligamentous endurance. In the dim light of rehearsal halls, ankles twist and give way, again and again, writing a painful refrain into the careers of those who live by balance and grace. Here, the anatomy of the sprain and the artistry of movement collide, each pirouette and landing carrying with it the silent risk of collapse.
But the story does not end with demographics. It deepens when we consider risk. Some individuals carry within themselves vulnerabilities that make their ankles more fragile, more susceptible to betrayal. A patient whose dorsiflexion is limited walks already at a disadvantage, the ankle joint deprived of its natural range of protection. Others suffer from subtle deficiencies in proprioception, that sixth sense of joint position that tells us where our body is in space. When that sense falters, even slightly, the ankle can no longer anticipate the ground beneath it, and a simple step becomes a gamble. Balance itself, too, plays a role. Those who lack it move with an invisible instability, increasing the likelihood that each stride could end in a twist and fall. The environment compounds this internal vulnerability. Certain sports seem designed to magnify the risk, their arenas echoing with the sound of rolling ankles. Indoor court sports, basketball, volleyball, and their kin stand at the top of this list. Their rapid shifts in direction, explosive jumps, and crowded landings create a perfect storm of forces, where athletes must constantly fight the betrayal of a joint that, while beautifully designed for mobility, is not always resilient to sudden, unnatural torque. The polished surface of the court, smooth and unforgiving, becomes both a stage and a trap, turning every sprint, every pivot, every leap into an invitation for injury. When we step back and look at these patterns, the ubiquity of ankle sprains in sport, the concentration among dancers, the vulnerability of those with impaired proprioception or restricted dorsiflexion, and the peril of the indoor court, we begin to see ankle sprains not as isolated accidents, but as the inevitable consequence of the body meeting its own limitations. They are predictable, even expected, where human anatomy collides with the demands of performance. In this way, epidemiology does more than provide statistics. It unveils the stage upon which this injury plays out over and over in athletes and non-athletes alike. To truly understand ankle sprains, we must look beyond their frequency and distribution, and instead peer into the very mechanics of how they occur. The ankle, a joint designed to carry the entire weight of the human body while granting remarkable freedom of movement, also harbors within itself an inherent weakness, a vulnerability that becomes evident in moments of sudden imbalance. The most common story begins with the foot placed in plantar flexion, that subtle downward point which unlocks the talocrural joint and loosens its natural stability. In that position, when an inversion force strikes, when the sole turns inward, collapsing against its own architecture, the ligaments are stretched past their endurance. It is here, in that sharp and sudden inward roll, that the classic ankle sprain is born. With each episode, the damage does not merely vanish. Ligaments, stretched or partially torn, rarely return to their original tautness, and so the ankle that has sprained once is more likely to sprain again, as if the memory of trauma lingers in its fibers. Over time, this repetition leads to what clinicians call functional instability, an ankle that no longer inspires confidence, one that falters on uneven ground, betrays the athlete in moments of stress, and becomes an ongoing source of pain and limitation. But not all sprains are created equal. They fall broadly into two distinct categories. The rarer of these, the so-called high ankle sprain, involves injury to the syndesmosis, the critical ligamentous complex that binds the tibia to the fibula. Though representing only 1 to 10% of all ankle sprains, these injuries are disproportionately sinister, for they disrupt not just one ligament, but the very structure of the ankle mortise itself. When the syndesmosis is torn, the two bones drift apart under the stress of weight-bearing, destabilizing the joint from within. Far more common, however, is the low ankle sprain, which accounts for well over 90% of cases. Here, the damage is focused on the lateral collateral ligaments, particularly the anterior talofibular ligament, the ATFL, and its partner, the calcaneofibular ligament, or CFL. These slender bands, though strong in appearance, are no match for the sudden force of inversion. Time and again, they yield, giving rise to the swelling, ecchymosis, and pain that define the archetypal ankle sprain. Yet ankle sprains rarely walk alone. They are often accompanied by hidden companions, associated conditions that complicate the story. Some patients developed osteochondral defects of the talus, small but treacherous injuries where cartilage and underlying bone fragment away, leaving the joint vulnerable to chronic pain and degeneration. Others suffer injuries to the peroneal tendons, the dynamic stabilizers that run along the outside of the ankle, tasked with preventing the very inversion they sometimes fail to stop. In certain cases, the shape of the foot itself conspires against stability. A subtle cavovarus alignment, invisible to the untrained eye, shifts weight laterally and predisposes the ankle to repeated trauma.
Within the joint, pathology can quietly brew. The most common of these is anterior or anterolateral synovitis, an inflammatory reaction born of repeated sprains that leaves the joint persistently painful and swollen. Osteochondral defects deepen the picture, while anterior ankle impingement, where scar tissue or bony overgrowth blocks motion, limits performance and prolongs suffering. Even the deltoid ligament, a great stabilizer on the medial side, is not immune, though isolated injuries here are vanishingly rare. When they do occur, the superficial fibers normally resist talar abduction, while the deep fibers check external rotation. Conservative treatment is often enough, but in those who live with unrelenting instability, reconstruction may become necessary. Sometimes the consequences are even more dramatic. A subset of patients, haunted by persistent pain long after the injury should have healed, descend into the debilitating spiral of complex regional pain syndrome, where the nervous system itself amplifies discomfort. In others, the violent inversion does not stop with ligamentous damage, but extends into fractures. The base of the fifth metatarsal may splinter, the anterior process of the calcaneus may yield, and even the talus, that keystone of the ankle, can suffer fractures of its lateral or posterior processes. Each of these adds a new layer of complexity, transforming what was once labeled a simple sprain into a far more dangerous injury. Thus, beneath the familiar surface of ankle sprains lies a rich and intricate pathophysiology. A single twist can set in motion not just ligamentous failure, but a cascade of associated injuries, from cartilage defects and tendon tears to subtle malalignments and fractures. What appears on the surface as common and benign, in truth, is a spectrum of trauma ranging from the trivial to the profound. To recognize this is to respect the ankle not as a trivial joint, but as a fragile masterpiece of engineering, capable of grace and strength, yet always just one misstep away from collapse. To appreciate the true nature of ankle sprains, we must descend into the architecture of the joint itself, for within its anatomy lies the explanation for both its strength and its fragility. The ankle is not merely bone and muscle, but a fortress bound together by ligaments, slender yet unyielding bands of connective tissue that tether bone to bone, preserving alignment and stability against the forces of daily life and athletic demand. Among these ligaments, the lateral complex stands as both protector and, paradoxically, the most frequent site of failure. The anterior talofibular ligament, or ATFL, sits at the forefront of this story. It is the most commonly injured structure in low ankle sprains, the very first line of defense that so often gives way. Its vulnerability stems from the mechanism of injury itself. When the foot is pointed downward in plantar flexion and then wrenched inward into inversion, the ATFL bears the brunt of that twisting force. Small in size and oblique in orientation, it is simply not built to withstand the sudden violence of such movement. On physical examination, its insufficiency reveals itself in the form of anterior drawer laxity, especially when the ankle is tested in plantar flexion. The joint slides forward too easily, betraying the quiet rupture of the ligament meant to hold it firm. But the ATFL does not suffer alone. Just behind it, the calcaneofibular ligament, or CFL, emerges as the second most common casualty of lateral ankle sprains. Unlike its anterior counterpart, the CFL resists inversion when the ankle is dorsiflexed, making it particularly vulnerable when the foot is forced upward and inward at the same time. When torn, its absence is subtler, harder to isolate, for it stabilizes not only the ankle joint itself, but also the subtalar articulation beneath it. The clinician, in searching for instability, may find themselves questioning whether the laxity they observe stems from the subtalar articulation or the posterior ankle itself. The truth is that the CFL contributes to both, and its failure creates an ambiguity that challenges even the most experienced examiner. The third member of this triad, the posterior talofibular ligament, or PTFL, is far less frequently injured. Stronger and more robust, it usually succumbs only in the setting of severe trauma, where the ankle is wrenched beyond the limits of ordinary inversion. Its relative rarity in clinical practice only underscores the disproportionate burden borne by its anterior and calcaneal counterparts. Together, these ligaments form the shield of the lateral ankle. They are the cords that prevent the talus from slipping, the anchors that hold the mortise steady, the guardians of motion that allow athletes to leap, pivot, and sprint with confidence. And yet, in the very moment they are most needed, in the sudden twist, the unguarded misstep, they too often fail. Their story is one of paradox, indispensable for stability, yet predisposed to rupture by the very movements they were designed to resist. When we consider the anatomy of the ankle in this way, the injury ceases to be a mystery. The ATFL tears because plantar flexion and inversion loaded beyond endurance. The CFL follows, torn in dorsiflexion and inversion. The PTFL, stronger but not invincible, breaks only in the most extreme cases. Each ligament speaks its own language, and each tells the examiner a different truth, revealed in drawer tests and patterns of instability. In learning to listen, the clinician gains not only the ability to diagnose, but also the wisdom to predict how the injury will unfold.
Once the anatomy is understood, the next step is to classify the injury, to give it a name, a grade. a framework that allows both doctor and patient to understand what lies ahead. Low ankle sprains, the overwhelming majority of these injuries, are divided not merely by the ligament involved, but by the degree of structural disruption, the extent of swelling and ecchymosis, and the severity of pain with weight-bearing. This gradation reflects a spectrum that ranges from the mild and fleeting to the devastating and chronic, from the ankle that heals within days to the ankle that may never fully recover. At one end of this spectrum lies the Grade 1 sprain. Here there is no true ligamentous tear, only the subtle stretching of fibers strained beyond their normal elasticity. The swelling is minimal, the ecchymosis faint if it appears at all, and the patient often surprises themselves with the ability to walk, sometimes even to continue activity at the moment of injury. Pain is present, yes, but fleeting, a warning rather than a declaration of damage. For many, this is the sprain that fades into memory, gone as quickly as it came. But for others, the insult cuts deeper, and we arrive at the Grade 2 sprain. In this stage, the ligament is not fully torn, but it is no longer intact either. Its fibers are stretched and partially disrupted, like threads fraying under tension. The swelling becomes moderate, the ecchymosis unmistakable, blooming across the skin in mottled hues of purple and blue. Weight-bearing is painful and hesitant. The ankle feels uncertain, unreliable. Though not a complete rupture, this is no trivial injury, for it leaves the patient vulnerable to prolonged recovery and, if mishandled, to future instability. And then there is Grade 3, the full measure of ligamentous failure. Here the ligament does not stretch, does not partially yield, it tears completely, severing the connection between bone and bone. The swelling is severe, the ankle grotesquely distorted by fluid and blood. Ecchymosis spreads wide, and every attempt at bearing weight brings searing pain, if walking is possible at all. This is the sprain that lingers, the injury that reshapes the athlete's season, sometimes their career. It is not merely a bruise of soft tissue, but the collapse of the ankle's foundational support. The symptoms of these injuries follow a familiar script, though each patient tells it in their own words. Pain with weight-bearing is the constant refrain, whether mild or severe. Swelling and ecchymosis emerge soon after the trauma, external signs of the internal violence done to the ligaments. For some, instability becomes a haunting presence, each step uncertain, each movement shadowed by the fear of another twist. Others describe a catching or popping sensation, particularly those who suffer recurrent sprains, as though the joint itself whispers of its fragility with every shift. On physical examination, the body reveals more than the patient may know. There is often focal tenderness over the involved ligaments, the examiner's fingers eliciting sharp pain as they trace the course of the ATFL or CFL. Swelling, too, marks the site of injury, guiding the hand toward the damaged structure. Special tests attempt to bring this instability into the open. The anterior drawer test, designed to reveal excessive forward displacement of the talus relative to the tibia, serves as a clinical window into ATFL insufficiency. Though its value in the acute setting is limited by pain and guarding, it remains a cornerstone of diagnosis, particularly when performed with the ankle in plantar flexion to stress the ATFL and in dorsiflexion to challenge the CFL. Alongside it, the talar tilt test adds another dimension. By forcing the ankle into inversion and comparing the result to the uninjured side, the examiner looks for asymmetry, for an angle of greater than 15 degrees, which betrays injury not just to the ATFL, but also to the calcaneofibular ligament. In those extra degrees of motion, in that silent testimony of torn stabilizers, lies the unnatural freedom of the talus. Taken together, these classifications and examinations transform what might seem like a simple twist of the ankle into a carefully graded diagnosis.
Each sprain is not merely an accident, but a measurable injury, charted along a spectrum of severity, each grade carrying its own prognosis, its own treatment strategy, and its own risk of recurrence. To name an ankle sprain as grade 1, 2, or 3 is not just to classify, but to begin the journey of healing with clarity and foresight.
While the history, classification, and physical examination provide much of what the clinician needs, there are times when the story of the ankle sprain cannot be fully told without the silent testimony of imaging. Yet, in the modern approach, radiographs are not ordered indiscriminately. Instead, they are guided by carefully validated clinical rules, a framework known to physicians around the world as the Ottawa Ankle Rules. These rules act as gatekeepers, ensuring that radiographs are obtained only when suspicion of fracture is real and sparing countless patients the unnecessary burden of radiation when the injury is clearly ligamentous in nature. According to these criteria, radiographs are indicated when the patient is unable to bear weight, when there is exquisite tenderness over the medial or lateral malleolus, when pain localizes sharply to the base of the fifth metatarsal, or when palpation of the navicular bone elicits discomfort. When any of these signs are present, the clinician must not hesitate, for the Ottawa rules are remarkably sensitive, with a capacity to rule out fracture in up to 99% of cases. In this way, the rules stand as both shield and sword, preventing overuse of radiographs and yet ensuring that no significant fracture is overlooked. When radiographs are obtained, the standard ankle series becomes the foundation of assessment. These are weight-bearing images, for it is under the load of the body that the true stability of the ankle is revealed. The anteroposterior view, the lateral, and the mortise each offer a different window into the architecture of the joint. On the lateral film, anterior translation of the talus may whisper of an ATFL injury. On the mortise view, the congruence of the tibial plafond and talar dome is carefully scrutinized, searching for any asymmetry, any widening that hints at deeper disruption. But there are moments when standard films are not enough, when suspicion of syndesmotic injury clouds the picture. In such cases, the external rotation stress view can be decisive. By forcing the talus outward, this view reveals the sinister signs of diastasis, widening of the medial clear space beyond 4 millimeters, or a tibiofibular clear space that stretches to 6 millimeters or more. Each millimeter here is not merely a measurement, but evidence of ligamentous failure, a widening gap that transforms a low sprain into the dreaded high ankle sprain. Other stress views add further clarity. The varus stress or talar view serves as a diagnostic key for CFL injury. By measuring the angle of inversion of the talus within the mortise, the examiner can quantify instability, exposing the loss of constraint that the calcaneofibular ligament once provided. In these degrees of tilt, the radiograph becomes a map of failure, outlining not just the presence of injury, but its functional consequences. And yet, even with these tools, some stories remain hidden from plain film. When pain lingers 6, even 8 weeks beyond the initial injury, when symptoms refuse to resolve despite appropriate therapy, the suspicion deepens that something more elusive may be at play. In these cases, magnetic resonance imaging becomes the investigator of choice. MRI peers beyond bone and alignment into the very substance of soft tissues. It can unmask the pathology of the peroneal tendons, those dynamic stabilizers often strained or torn in the violence of inversion. It can reveal osteochondral injuries, where cartilages of chondral bone have quietly fractured away. It can diagnose subtle but devastating syndesmotic injuries that no plain film could ever capture. Thus,
Imaging is not merely an accessory to the story of ankle sprains. It is a language in itself, one that speaks in shadows and contrasts, in widening spaces and invisible tears. It confirms what the clinician suspects. It reveals what the examination cannot, and it guides the path forward when recovery falters. Once the diagnosis is made, once the ligaments have spoken their story through swelling, tenderness, and radial relapse, the question turns to treatment. And here, the philosophy of modern orthopedics reveals a stem. For the most part of ankle sprains, healing is not coaxed by the knife, but by time, structured care, and the intelligent application of movement. The central principle is simple, yet profound. Immobilize just enough to allow tissues to recover, then move as soon as possible to restore strength, balance, and trust in the joint. Non-operative management forms the foundation of care, and it begins with the familiar acronym RIGHTS: rest, ice, compression, and elevation. The ankle, engorged and tender, responds to these measures with a reduction in swelling and pain, a reprieve from the acute storm of inflammation. An elastic wrap or compressive dressing adds further control, containing the swelling before it spirals beyond the body's ability to manage. Yet this is only the beginning. Immobilization has a role, but it is fleeting. For many, a short period of weight-bearing immobilization in a walking boot, air cast, or lightweight walking cast is sufficient to protect the injured ligaments during their most vulnerable days. But the key is always that immobilization must give way to mobilization. Prolonged stillness weakens the joint, and the longer the ankle is locked in rigidity, the harder its return to motion. Even in grade 3 ankle sprains, the most severe, immobilization rarely extends beyond 10 days of casting and non-weight bearing. Beyond that, the priority shifts toward restoring movement. Rehabilitation becomes the cornerstone of healing. In the early phase, therapy begins gently with range of motion exercises that reawaken the joint. As pain and swelling diminish, the focus sharpens on strength, particularly the perineal muscles that serve as dynamic stabilizers against inversion. Proprioception training becomes equally essential, retraining the ankle to anticipate the ground, to sense its place in space, to resist the betrayal of another twist. Progressively, activity-specific exercises are introduced, mimicking the demands of sport, bridging the gap between therapy and full return to competition. During the strengthening phase, external support continues to play a role. Functional braces that limit inversion and eversion provide security during rehabilitation, and for many athletes, these braces become companions in the long term, worn prophylactically during high-risk activities like basketball or volleyball. They do not eliminate risk entirely, but they provide reassurance and measurable reduction in recurrence, a reminder that technology can lend its hand to biology. The outcomes of this non-operative approach are remarkably positive in most cases. Early functional rehabilitation consistently demonstrates the fastest return to physical activity, and while SWIT provides physical therapy, offers clear benefits in the early weeks of recovery. Long-term outcomes remain largely the same, whether the exercises are guided in a clinic or practiced faithfully at home. There is, interestingly, no convincing evidence that the seeds of traumatic instability can be predicted by history, physical examination, or radiographic findings. The ankle's destiny, it seems, is shaped not just by the initial injury, but by how it heals, how it is retrained, and how faithfully the patient adheres to their rehabilitation.
Yet, for some, non-operative care is not enough. When instability persists despite months of therapy, when pain lingers in defiance of exercise and rest, when recurrent sprains reduce the ankle to a fragile hinge rather than a stable joint, surgery becomes the next chapter. Operative management offers two broad paths: anatomic reconstruction of the torn ligaments, restoring them to their native configuration, or tendon transfer with tendonitis, recruiting alternative tissues to stabilize the joint. The choice depends on anatomy, chronicity, and the surgeon's philosophy, but the goal is the same: to rebuild stability where natural healing has failed. Arthroscopy often plays an accompanying role. It is not only a tool for reconstruction, but also a diagnostic window into the joint. For patients with recurrent sprains or chronic pain, arthroscopy allows the surgeon to peer inside, to identify and debride impinging tissue, whether the anterior-inferior tibiofibular ligament fraying into the joint or a posteromedial impingement lesion causing persistent discomfort. By removing these sources of irritation, arthroscopy clears the way for a more complete recovery, often preceding or complementing reconstruction. Thus, treatment of ankle sprains is not a one-size-fits-all prescription, but a spectrum that mirrors the injury itself. From RICE and bracing to advanced rehabilitation, from careful immobilization to surgical reconstruction, every decision reflects a balance between rest and motion, biology and intervention, patience and precision. In this balance lies the art of healing, guiding the patient from the vulnerability of injury back to the strength of trust in every step. When conservative measures fail and the ankle remains unstable, the surgeon steps into a role not of healer by rest, but of architect, reconstructing what the body has lost. Among the most trusted operations for chronic lateral ankle instability stands the anatomic reconstruction known as the Broström procedure, often performed with a modification introduced by Gould. In essence, it is a shortening and reinsertion of the anterior talofibular ligament and calcaneofibular ligament, restoring them to their native orientation. But the genius of the Gould modification lies in its reinforcement. Here, the inferior extensor retinaculum and the periosteum of the distal fibula are incorporated into the repair, lending additional strength and stability to ligaments that have failed under the strain of repeated trauma. This repair, though elegant, demands precision. If over-tightened, it may leave the patient with diminished dorsiflexion, the ankle robbed of its natural range of motion in exchange for stability. And yet, when performed with balance and care, the results are consistently impressive. Good to excellent outcomes in 90% of patients, a return to confidence in movement, a reclaiming of athletic potential. Many surgeons advocate for arthroscopic evaluation prior to reconstruction, peering into the joint to search for interarticular pathology that might complicate recovery, ensuring that no hidden lesion is left untreated before stability is rebuilt. But anatomic reconstruction is not the only path. Some surgeons turn instead to non-anatomic reconstructions, tendon transfers and tendonitis that sacrifice one structure to reinforce another. Techniques bearing the names of Watson-Jones, Christman-Stuck, Colville, and Evans each describe variations on this theme, the rerouting of tendons to replicate the stabilizing function of the torn lateral ligaments. These procedures may seem less elegant, less faithful to the original design of the ankle, but they offer their own advantages, particularly in cases where tissue quality is poor
or previous reconstructions have failed. Here, attention to alignment becomes critical. A lateral ligament reconstruction performed without first correcting underlying malalignment is destined to fail, for even the strongest graft cannot resist the persistent force of a misaligned hind foot. To distinguish between fixed and flexible deformities, surgeons employ the Coleman-Plak test, a simple yet profound maneuver that reveals whether a cavo-verist foot can be corrected or remains rigid. This test guides the hand of the surgeon, reminding them that ligament repair alone cannot succeed if the foundation of the foot itself is unstable. But even with careful technique, complications are not absent. Subtalar stiffness emerges as a common consequence of these tendon transfer procedures, a trade-off between stability and motion that patients sometimes must accept. The ankle, if now reinforced, may lose some of its natural fluidity, its subtalar joint bound more tightly than before. It is a compromise, one that must be weighed against the instability and repeated sprains that drove the patient to surgery in the first place. And so, the spectrum of operative treatment reflects the balance between anatomy and adaptation, between restoring what nature designed and substituting what has been lost. The Gould-modified Broström stands as the gold standard, an anatomic reconstruction that honors the original blueprint of the ankle, while tendon transfers offer an alternative, a means of stability when native ligaments cannot be salvaged. Both roads lead toward the same goal, an ankle that can once again be trusted, an athlete that can once again move with a fear, and a joint that, though scarred by injury and surgery, is strong enough to carry its burden into the future. The story of an ankle sprain does not end with surgery, nor even with the initial phase of healing. Recovery extends into the long weeks and months of rehabilitation, where the joint must be retrained, strengthened, and reawakened. In this stage, timing becomes just as critical as technique, for the debate between early and delayed mobilization has shaped much of modern practice. Those who champion early mobilization within the first 3 weeks after injury or surgery point to improved functional scores, faster gains of strength, and a quicker return to activity. The ankle, they argue, is not designed to linger in stillness. Its ligaments and muscles thrive when challenged, when reminded of their role in stability. And yet this approach carries risks. Early mobilization can stretch tissues still vulnerable, increasing the degree of laxity in the joint. It can also interfere with wound healing, exposing patients to complications that prolong recovery. The alternative, delayed mobilization beyond 3 weeks, offers protection, but at the cost of slower functional return. And so, the clinician must balance speed with security, ambition with patience.
Return to play remains the question at the forefront of every athlete's mind, and the timeline is dictated by the grade of sprain, the presence of syndesmotic injury, associated lesions, and above all, the patient's adherence to rehabilitation. For the mild grade 1 or 2 injuries, return is often possible within 1 to 2 weeks. The ankle regains confidence quickly once swelling has resolved. Grade 3 sprains, with their complete ligamentous disruption, demand more time, typically 3 to 4 weeks. Hide ankle sprains complicate matters further. If treated with simple immobilization, athletes may be sidelined for 5 to 6 weeks. If managed with screw fixation, the season itself may be lost. These numbers, though clinical, are not guarantees but estimates, for every ankle heals at its own pace, and every athlete carries their own threshold for risk. Prevention, however, offers a way to rewrite this narrative. For athletes with a history of sprains, protection can mean the difference between recurrence and resilience. Semi-rigid orthoses provide external support, limiting the motions that so often lead to injury. In those with cavovarus alignment, bracing can be tailored,
Lateral in-foot or forefoot wedging, combined with a recess for the first metatarsal, redistributes forces and prevents the ankle from rolling outward. Strengthening the everter muscles, especially the peroneals, adds dynamic resistance against inversion, while proprioception exercises sharpen the joint's awareness of position, reducing the risk of misstep. Perhaps most importantly, prevention must be sustained. A season-long program, rather than short bursts of training, offers the most meaningful reduction in recurrence. Yet, even with meticulous treatment and prevention, complications remain. Up to 30% of patients continue to experience pain and instability long after an acute sprain. The reasons are many, and often a lion once was missed at the time of injury. Small fractures, the anterior process of the calcaneus, the lateral or posterior process of the talus, the base of the fifth metatarsal, may escape initial detection, only to manifest later as chronic pain. Osteochondral lesions of the talus, injuries to the peroneal tendons, syndesmotic tears, and tarsal coalitions can all masquerade as simple sprains, only to reveal themselves through persistence. Impingement syndromes, hand-foot varus alignment, even neuropathic pain from stretch neuropathy can complicate recovery, leaving patients with symptoms that defy the expected course. The prognosis, however, is not without hope. In the natural history of ankle sprains, pain tends to diminish rapidly during the first 2 weeks, a steep decline that reassures both patient and physician. But beyond that, recovery is more variable. Between 5 and 33% of patients report lingering pain 1 year after the injury. And perhaps most concerning, once an ankle has sprained, the risk of recurrence rises not only in the injured ankle, but in the contralateral side as well. As if instability begets instability, and one joint's failure foretells another's vulnerability. And so, the story of ankle sprains is not of trivial injury, but of complexity and consequence. From mechanism to classification, from anatomy to treatment, from rehabilitation to long-term outcomes, each step reveals layers of fragility and resilience. The ankle, a joint that seems simple in its daily function, is in fact a delicate balance of bone, ligaments, tendon, and proprioception, capable of extraordinary feats, yet undone in a single misstep. For the athlete, the dancer, the ordinary walker on uneven ground, it serves as a reminder. Stability is precious, trust in the body is fragile, and recovery is not a moment, but a journey. Please subscribe.